awareness. Hey, welcome everyone. Neela, I think we can go ahead and get started if you'd like.
Sounds good. Thanks, Colin. Good afternoon, everyone, and welcome to our first September CME webinar series offered by the Medical Society Consortium on Climate and Health. I'm Neela Tamala, and I am a clinical assistant professor of surgery at George Washington University and a climate and health advocate. The next 10 years is a critical window of opportunity to avoid the worst consequences of the climate crisis. To meet this challenge, national medical societies, in partnership with state medical societies, public health, nursing, and other health professional societies, have come together with a shared conviction that climate change is a health emergency that must be overcome. The consortium also welcomes individual climate and health advocates. You can sign up on the website docsforclimate.org. Our shared goal is to create a future where all people have clean air, clean water, and nutritious food, and where the climate has returned to a stable state. This webinar is part of a series of 4 webinars for credit that the consortium is offering during the month of September. After today, the other webinars are on September 11th, 18th, and 25th. Before we get started, a few housekeeping items. Please place your questions into the Q&A space. We will post them after the speakers have finished speaking. CME credit is available for this webinar, but we had a little bit of a technical snafu, and we'll be having to email you all the link for the CME credit. If we're able to get the link today, we'll do it today. Otherwise, it may be next week. But don't worry, everyone who has been on this webinar will get an email with the CME credit link, and you'll be able to get your credit. Presentations will be available on the consortium website at docsforclimate.org, and an email will arrive after the webinar with links to the presentations, a tape of the webinar, and then obviously the CME questions and the certificate. I would like to thank our supporters, and I would like to thank Colin Nakamick for running the Zoom meeting today. So without much further ado, let me introduce our first speaker, Dr. Caitlin Rublee. She's an assistant professor of emergency medicine at the Medical College of Wisconsin and faculty in the Institute for Health and Equity. She completed her medical and master's of public health degrees at the University of Wisconsin School of Medicine and Public Health, followed by residency at The Ohio State University, serving as chief resident. She recently completed a 1-year climate and health science policy fellowship at the University of Colorado. She serves as the current chair of the Society of Academic Emergency Medicine, Climate Change, and Health Interest Group, and is on the board of directors for the Wisconsin Health Professionals for Climate Action. Apart from all of these things, Dr. Rublee has also been helping me organize these webinars. I'm incredibly excited to hear her speak today. Thank you.
All right, thank you, Nilu. It is my pleasure to talk to you about building healthcare facility resilience today. Essentially, how we can prepare our own healthcare systems and institutions against extreme weather events that are coming in the coming months and years. Now, I just want to acknowledge the last few weeks. Without a doubt, many, if not all of us, are personally and professionally impacted by the named and unnamed storms that I'm going to talk about today. We have seen wildfires across California and Colorado, wildfire smoke that blankets half of the country. We've seen the derecho across the Midwest, extreme heat, and most recently we've seen hurricanes. Hurricane Laura, just one example, yet again, of the impact to patients and employees. So as we talk about building resilience today, I want us to remember the people, and that's why it is imperative as we move forward to address these issues. Now I wanted to start here. This is the Major League Baseball stadium I drive past every day on my way to the emergency department. Essentially, it was constructed with a lens towards weather. It has a retractable roof. During rain and storms, the roof closes within about 15 minutes. The game can go on. Players can play, observers can watch, and we see that the show goes on. Now, as I talk about many of these events today, I want you to think about your own arenas. Think about your endoscopy suites, your surgical suites, your emergency departments, your clinics. Think about the threats locally that could disrupt healthcare services or access to care for many of the patients you serve. And lastly, think about what you need in order to provide the care you do, from running water, wastewater systems, energy and electricity. I want you to think through your own lens of what your community needs and what you need as a healthcare professional. Many of the examples I'll use today are hurricanes. They're severe storms. That's what most of the literature is on. But without a doubt, many storms impact healthcare service delivery that are far less extreme. So in short, I'm going to talk about extreme weather events, the impact to people and the financial impact to healthcare facilities and healthcare systems. I'm going to give you concrete cases that highlight disruptions in care for our patients. And lastly, and most importantly, I'm going to give you toolkits and guidance documents that you can take back to your own facilities in order to build resilience against local vulnerabilities to your healthcare systems. The Intergovernmental Panel on Climate Change is a leading scientific body. And when it comes to disasters and extreme weather events, here's what they have to say. Direct and insured losses from weather-related disasters have increased substantially. Impacts from recent climate-related extremes reveal significant vulnerability and exposure. And these climate-related hazards exacerbate other stressors, often with negative outcomes for livelihoods. Once again, we see how social and environmental determinants of health impact people. Now, this is one example after Hurricane Maria. Essentially, the number of excess deaths was more than 70 times the official count after a survey was done. And here's what the authors had to say. They said interruption of medical care was the primary cause of sustained high mortality rates in the months after the hurricane, a finding consistent with the widely reported disruption of health systems. Time and time again, we see that not only the acute stressors and acute insults impact care in the immediate sense, but for months to years following the events. This loss of access impacts people, but disproportionate loss of access to these health services can further exacerbate health disparities. As an emergency medicine physician, I know that high utilizers are extremes of age, the very young and the very old. They're residents of nursing homes, they're undomiciled populations, they're people of color. Unfortunately, in the United States, millions of people are uninsured and underinsured, and such, their primary source of healthcare is emergency care. Disruptions in access and service delivery to these patients can impact morbidity and mortality as we have seen time and time again. Now, these events are not only costly in terms of human lives, but also in regards to financial dollars. The number of billion-dollar disaster events have been increasing. So down here, you can see this black line is the average from 1980 to 2020. There are just over 6 events per year. In 2020, we're already up here with this red line at 10 events. It has been the 6th consecutive year with 10 or more billion-dollar disaster events. And many of these events exceed $1 billion. So looking at 2018 Hurricane Michael, almost $20 billion, with much of it being loss of property and loss of infrastructure. Now I just want to highlight a few cases that really expose these disruptions in care. Wildfires. 2018 was a terrible year for wildfires. More than 58,000 fires, and across the United States, well over 1,000 significant fires defined as burning more than 40,000 acres. Feather River Hospital was just one example. The Camp Fire hit and 280 people had to be evacuated. These were patients and employees. What's more is after the fires, the Pacific Gas and Electric Company shut off powers to prevent future fires. Those disproportionately impacted were community health centers, which serve underserved populations. Some surveys showed that only 44% of these community health centers had some sort of backup power, which was relied upon for refrigeration of vital vaccination stores and medications like insulin. Hurricanes. Now there's a lot of literature on hurricanes. Going back more than 30 years ago, 1989, Hurricane Hugo was one of the most destructive hurricanes to hit South Carolina in more than 2 decades. I bring your attention to this Norcross article for those in the surgical services because it highlights the disruptions for surgeries. Since that time, we have had a myriad of named storms. In 2017, Hurricane Maria hit Puerto Rico. Puerto Rico at that time was the largest foreign producer of pharmaceuticals for the United States, employing 90,000 employees. They were large producers of intravenous fluids, medications, and cardiac devices, such as pacemakers. What we felt in the United States were intravenous fluid shortages that lasted well beyond a year. This impacted medication delivery in the hospitals, such as antibiotics or anticonvulsive medications. Superstorm Sandy was another example in 2012. Essentially, it hit New York and resulted in 43 deaths and more than 6,000 patients being evacuated from 37 healthcare facilities during or after the storm. These healthcare facilities said time and time again, we were surprised. We were surprised that we had to evacuate. We were surprised that we had to take in more patients from evacuated hospitals. I also want to note that these hospitals were safety net hospitals, and they served low-income people and people who relied on emergency care as their only source of care. And there are many examples of research following the events showing increase in emergency department visits, for example, for homelessness. This is just a depiction of the many different failures that resulted in closures and evacuations during Superstorm Sandy that was collected in interviews following the storm. You can see everything from utility power outages, failed generators. Many of these backup power sources were left in flood-prone basements. I also want to bring your attention to staff absenteeism. Staff that couldn't even travel to work or didn't have childcare, for example. Tornadoes and extreme storms across the Midwest. In 2011, Joplin, Missouri had an EF5 tornado hit their medical center, 200 miles per hour. There were 6 deaths that resulted, 5 of which were patients. Essentially, they used 96 hours worth of emergency equipment in only 4 hours, and there was significant destruction to medical documentation. Extreme heat. Now, I just want to remind you that not all hospitals have heating and cooling capabilities. And so this one article is from a hospital in India, and essentially their hospital didn't have air conditioning. And it resulted in an increase in neonatal intensive care unit admissions for heat within their hospital during a heat wave in 2010. There were 24 admissions. In previous years, there were only 4 or 8 admissions. And then I also want to remind you, these hurricanes and storms shut off powers, and that means loss of air conditioning. Nursing home residents have died, and there are several other examples similar to this. Lastly, we have dust storms. In the Southwest United States, this study found an increase in total intensive care unit admissions of 5% on the day of the dust storm at nearby hospitals, and an increase of 9% for respiratory admissions alone. So it causes surges in demand, and that means for hospital personnel as well as for medications. Now that was a lot of information, and so I just wanted to summarize it for you. Essentially, there are various climate change hazards that impact facilities. We are focusing on healthcare facilities themselves. So we have extreme heat, drought, wildfires, flooding, and with these facilities, there are direct and indirect impacts that affect care. They affect healthcare service delivery and access to care for patients. We can talk about transportation systems and impacts on helipads, for example, flooding or ambulance transport for patients, energy disruptions, loss of food and medications that are relied upon by staff. So what are we going to do about it? Essentially, it comes down to building resilience. This is the Intergovernmental Panel on Climate Change definition, but essentially it is how do we ensure our facilities remain operational even during times of stress? How can we ensure that they are able to provide care for our patients? The World Health Organization has a framework. It's essentially 10 components of building climate resilient healthcare systems. You can see the different components here: leadership and government, health workforce, health information systems, essential medical products and technologies, service delivery, and financing. If we break this down even more, you can see that health systems undergo different stressors and shocks. I think this slide gets a little bit busy, but what I want you to do is look at the right side and the outcome options. How do we make it so that every outcome is transformed and recovered better than before, rather than collapsing as a system? How can we ensure that services can be delivered? Different countries have created resiliency toolkits for healthcare facilities. So these are essentially guidance documents that can be taken and brought back to healthcare systems and institutions. I'm going to give you a lot of different examples of how facilities have utilized these guidance documents, but we'll focus on the right two. So in the United States, the Department of Health and Human Services has the Sustainable and Climate Resilient Healthcare Facilities Toolkit. It's specified for hospitals, residential care facilities, ambulatory care, and home care. And it's essentially a 5-element framework. And then it has several checklists where it helps healthcare systems identify their own vulnerabilities. The Pan American Health Organization also has a Smart Hospitals Toolkit and initiative. It's focused on hospitals, and we'll talk a little bit about that one as well. Again, for the United States, I encourage you all to go to toolkit.climate.gov. Type it in your phone now and explore it. Again, it has 5 different elements. It has various checklists and guidance documents in order to instruct healthcare systems on changes that they can take. Here are a few examples. The University of Texas Medical Center was hit in 2001 by Tropical Storm Allison. Now, this is an enormous medical center of more than 700 acres. And essentially, several hospitals had to be evacuated. There was significant flooding around the facilities, and it resulted in significant disruption in care for patients. What the community did after was get together, and they developed a hazard mitigation plan. They engaged stakeholders from multiple disciplines and sectors, and they were able to relocate their utility plants and critical infrastructure. When Hurricane Harvey hit in 2017, it was a different story. They were able to remain operational without evacuations. Here are just a few pictures. You can see the floodgates that protected employee parking garages, for example, as well as expanding the bayou to reduce flooding around the medical center itself. Spalding Rehabilitation Hospital in Boston is another example. Essentially, they used the latest climate science to build their hospital. They elevated the ground level floor based on the duration of the building. They put backup power and critical infrastructure on the roof. And they reinforced infrastructure against storm surge. San Diego Medical Center was created as a green hospital. And what their leadership team said was, it costs no more to create a green hospital than it would have to create a regular hospital. One of the things they invested in was energy resiliency. And you can see there, they have solar on the roof of their entire hospital. This is just a reminder that solar prices continue to drop, and we are at an all-time low. Nicholas Children's Hospital in Florida, essentially they updated their exterior to withstand a Category 4 hurricane force winds. Previously, they could only withstand a Category 2 hurricane. What happened then was they were a refuge for many people who were displaced. When Hurricane Wilma hit, as well as Hurricane Katrina hit, they were able to take in many sick children who had congenital heart disease, for example, and had to be evacuated from Puerto Rico. They also took in about 60 other children who required energy for mechanical ventilation and healthcare needs. Vancouver Coastal Health, as a system, has defined this new climate reality. Essentially, they're incorporating a climate lens into any new construction of healthcare facilities or retrofitting of existing facilities. I encourage you all to go to this case study and look at it more, but they're predicting future temperatures, extreme heat, as well as precipitation, and using it when constructing their hospitals. They also have employee trainings centered on climate and health. And lastly, I want to share the Smart Hospitals Toolkit in South America and the Caribbean. Essentially, there's a hospital safety index, a checklist, and a cost-benefit analysis. Georgetown Hospital is just one example. They installed solar and updated their exterior infrastructure and found a 58% reduction in electrical consumption following the updates. They also fixed leaking faucets and just did basic infrastructure updates to reduce water losses. And this is one of my favorites. People's Hospital in the British Virgin Islands. Essentially, People's Hospital constructed itself to be a Category A hospital according to the Smart Hospital Initiative, the very best. Now, when Hurricane Irma hit, it was a Category 5 hurricane, the strongest there is. It devastated many parts of the community, but People's Hospital remained strong. They remained operational with only a few fractures in the window panes. The government actually took up emergency operations there, and it became a headquarters to run the entire emergency operations following the storm. It was a beacon of hope that the community could rely upon during the storm. This idea of healthcare facility resilience and building resilience is part of climate smart healthcare. And so one edge of it is resilience, but the other side of it is low carbon healthcare or environmental sustainability. Later this month, we will have a few speakers talk about this environmental sustainability, but really there is still some overlap and they should be thought of as a pair. All right. Now, what can you do to help your patients plan? In addition to taking these guidance documents and toolkits to your healthcare facilities, you can also do this. September is National Preparedness Month. There is a whole bunch of guidance documents online. You can go to ready.gov that you can give out to your patients and discuss with them to address local vulnerabilities. Healthcare Ready has advice for medications and addressing healthcare needs. If your patient requires dialysis, for example, do they have a plan in place if there is flooding? And then thirdly, addressing vulnerabilities of your patients that you identify. This is just one example. Our electronic health records, EPIC, has this social determinants of health wheel, and it identifies different domains. If a patient doesn't have access to secure housing, how can you help them to think about what to do in the setting of a heat wave, for example? All right, we talked about a lot of information. Here's what I want you to take away. We need preparedness instead of just response. They should be seen as a partnership, and we can start now preparing our healthcare facilities to transform. We can choose to transform and recover better than before, rather than evacuate every single time. And we need you. These toolkits need to be utilized and implemented in communities in order to keep our own arenas operational. You know what you need best. And in order to care for your patients, we need your voice and our voice together to work as communities to build resilience. All right.
Thank you, Caitlin. And I think we're now going to screen share. And I'm excited to now introduce you to Dr. Ashley Mcclure. Dr. Mcclure is a Seattle native who went to medical school at Oregon Health and Science University in Portland and trained in internal medicine at the University of Washington. She now practices primary care in Salud and Español in Oakland. Since her climate awakening, she's been organizing within and beyond her own medical group. She's engaged in organized medicine, introducing climate-related resolutions as a CMA delegate and AMA alternative delegate. She also co-founded the California-based nonprofit Climate Health Now, whose mission is to activate colleagues to use their uniquely trusted voices to advocate for policy-level climate solutions in order to protect health. She welcomes your reaching out if you're inspired to link arms in advocacy, and she hopes you do, as she believes that only together will we be powerful enough to save everything we love. Love that, Ashley, and excited to hear your thoughts.
Great, thank you. It's a pleasure to be with the consortium community, and especially a thank you to Nilu and Dr. Sarfati for the invitation to be here, and thanks, Caitlin, for an awesome presentation. And then lastly, just a call out to Mary Sweeters, who's my kind of co-lead in the divestment campaign that I'll be talking about today. So it's a very special experience to be in a community of physicians and health professional colleagues who share an understanding of the climate crisis as a health emergency. So you know, sometimes, yeah, it's hard because not everybody understands that. So I'm really glad to be here and to have a lot of kind of shared understanding of what we're facing as a health crisis. So I am, let's see, can everybody see my screen? We're good? Okay, great. So I'm here to share about an opportunity for channeling that shared concern and channeling our powerful social influence into an effective action to help kind of foster the clean energy transition through a health professional-led fossil fuel divestment campaign that is targeting U.S. health insurance companies. Like many of you, I chose to become a physician, motivated by promoting healing and health. And I had known about global warming for years, but I became a mom in 2018, and that's the same year actually that the campfire that Caitlin mentioned, that's really what kind of activated me to engage in climate, because I was at home with a 5-month-old baby, and we were stuck inside with an air purifier in that fire that Caitlin mentioned. And that, along with having a daughter and skin in the game in a new way for the future, is really what made me kind of come to terms with how to maximize my contribution to solving the climate challenge in order to protect everyone and everything I love. So fortunately, oh, sorry, I missed. Oh, man. I'm so excited talking to you. I forgot to do the pictures. That's that fire. That's my daughter, my motivation. And it's just a visual of leveraging our uniquely trusted voice in the climate movement to protect health and humanity. Nurses are the most trusted, as I'm sure many of you know. Physicians come in a close second, and really I see our voice, our social influence through our voice as our climate advocacy superpower. And pharmacists are a third. And we earn this trust through our altruistic commitment to prioritizing the health and safety of our patients above all else, no matter if the right thing to do is inconvenient, like missing our lunch break to take care of a complicated patient, or if the right thing to do is personally terrifying, like putting on your PPE to go see a patient that you think probably has COVID. But I'm proud to be, along with all of you, in a profession that really is committed to doing what it takes to take good care of people. And in the wake of the police killings of Black Americans like George Floyd, Breonna Taylor, Ahmaud Arbery, and way too many others, many in our profession are leveraging this powerful voice in fighting for social justice through movements like the White Coats for Black Lives movement. And as we all know, the fight for racial justice is tied inextricably to the fight for climate justice. And I really like, this is us here in Oakland. I really love this quote from a Sierra Club leader named Hop Hopkins, and he kind of captures a very complicated connection by saying, you can't have climate change without sacrifice zones. You can't have sacrifice zones without disposable people, and you can't have disposable people without racism. And these sacrifice zones exemplify where the social determinants of health instead determine disease. They tend to be poorer and have more people of color than in less polluted communities. Sacrifice zones are fossil fuel industry hotspots, like fracking operations in Southern California, coal mines in Montana, oil refineries in the San Francisco Bay Area where I live. And this is so important for us as health professionals, as all of you know, because no matter how well we provide medical care, where our patient lives and the air they breathe determines their lifespan more than we can in our offices and hospitals. So many of you probably heard of the recent article that the good Dr. Don Berwick wrote in JAMA, and he titled it "The Moral Determinants of Health." And I'm just pulling out a section that I feel is most relevant for us today, but really kind of inspires what I see as the call to action of our profession. So imagine for a moment that the moral law within commanded shared endeavor for securing the health of communities. Imagine further that the healing professions together saw themselves as bearers of that news and leaders of that change. What would the physicians, nurses, and institutions of the U.S. healthcare system insist on and help lead as an agenda for action? And he shares a short list, and of course, he includes restoring U.S. leadership to reverse climate change with other very, very important things. But it was a great article. I definitely would recommend it. And so I'm going to finish today with an invitation for you, dear Friday Consortium webinar attendees, to join as we launch a campaign that I think would make Dr. Berwick proud. And we are leveraging that trusted voice of nurses and doctors and medical students and all health professionals as spokespeople for a campaign. And the campaign is calling on, like I said earlier, U.S. health insurers to divest their investments from fossil fuels because they are incompatible with protecting health. So if you'd like to be looped in to getting updates about this and receiving more information, if Colin or Nilu or somebody, if you could post the Google form in the chat, that would be great. But that's the kind of way that you can get looped in to hear updates and perhaps be involved if you're interested. So despite their critical role in the U.S. healthcare industry, health insurers are currently acting against the best interests of their policyholders and the planet by investing billions of dollars of their premiums into fossil fuels, thus fueling the climate health crisis. So the most recent data we have from 2017 reveals that the country's top 10 health insurers invested nearly $24 billion into fossil fuels. And if you're interested, like I was, here's the specific breakdown of those top 10. So these are the top 10 companies whose chief investment officers and executive officers will be receiving a letter from our campaign coalition in the first week of October stating we as health professionals and a coalition that's not just health professionals, but we are calling on you to divest in order to have your investments be congruent with your mission. So these health insurers currently having their investments in fossil fuels are of course making our communities sick. They're fueling environmental racism in polluted sacrifice zones and exacerbating existing health inequities. So the moral clarity of our campaign's divestment demands, in combination with the current financial free fall of the fossil fuel sector, provides a very unique opportunity of timing to make fossil fuels more reputationally toxic and to help accelerate the rest of the insurance industry's exit, both in terms of underwriting fossil fuel projects and investing their money in fossil fuels. So the fossil fuel divestment movement is large and it's growing really quickly, and it's kind of aimed mostly at removing the social license of fossil fuel companies to operate, and also removing the capital available to fossil fuel companies to continue polluting and driving climate change. Today, over 1,000 global institutions have pledged divestment, totaling over $14 trillion, which has definitely already affected the fossil fuel industry. So Goldman Sachs Global Energy cited that divestment campaigns were a key driver of the coal sector having a derating in the past 5 years. And the movement's largest impact has been to delegitimize the fossil fuel industry, making it really socially unacceptable to invest in fossil fuel companies because of the harms. So our campaign is in very good company. The British Medical Journal, I'm sure many of you heard, announced its Investing in Humanity campaign earlier this year, an eternity ago, which is aimed at assisting health professionals and medical organizations in divesting from fossil fuels. 2 years ago, I believe Todd Sack is on this call, the American Medical Association passed a resolution that was in part related, if you haven't heard of it, the American Association of Public Health Physicians that Dave Cundiff is a part of also helped Todd Sack kind of move this resolution forward in the AMA, calling for divestment within the AMA. And then most recently, this is just from 3-4 months ago, the University of California completed its divestment of their pension and their endowment. So momentum is moving. And like I said, we're in really good company to build. So we have a coalition that's moving this specific campaign forward for health insurers. This is like my favorite slide by far because I think it's just really exciting to have these groups kind of linking arms to move this forward. So we have Insure Our Future, who has a ton of experience in divestment campaigns for insurance companies more broadly, life and casualty, I think. Along with Healthcare Without Harm, the American Medical Student Association, Medical Students for a Sustainable Future, Climate Health Now, which I'm a part of, Public Citizen, and also the Alliance for Nurses, Alliance of Nurses for Healthy Environments. So what we are focused on, the goals of our campaign are that one of the top 10 health insurers commits to divesting from fossil fuels by the end of this year. So we're hoping that just by getting the letter, there might be some that we can move really quickly. And then this kind of second tier goal is that 3 of those top 10 health insurers commit to divest by next June. So I don't have to articulate that these are bold goals, and our success is going to take a strong coalition linking arms together with persistence. But I know that as physicians and nurses and all health professionals, we show up and we are committed to doing what it takes to take good care of people. So the campaign demands specifically, in case it's of interest, is that these companies divest all of their assets from coal, oil, and gas, all of the assets that are not in line with the Paris kind of goals, which is all of them very quickly. And that they also bring their stewardship activities, trade association membership, and public positions more broadly in line with the Paris goals, including, of course, a green recovery from COVID, just recovery. So I will conclude, as actually Dr. Berwick did in his recent article, and I really like the way he put it, that healers are called to heal, and when the fabric of communities upon which health depends is torn, then healers are called to mend it, and the moral law within insists so. Improving the social determinants of health will be brought at last to a boil only by the heat of the moral determinants of health, and I really see this campaign as a way to turn up the heat in kind of securing the safety and future of everybody. So if you would like to be looped in for updates and to help promote the campaign in your circles, which would be really, really helpful, please share your info in this. It's just a 4-question Google form. We're still inviting organizational co-signers in the next couple of weeks, but also just if you want to be looped in as an individual. And it's also really helpful to kind of, when you do the Google form, which I hope you will, that you share kind of key organizations that you're a part of, just so we can kind of map where we have connections. So that's, and then lastly, just to clarify again, our launch is in about 4 weeks. We're shooting for the first week of October. So thank you, and eager to have some conversation. And if you want to be in touch, there's my email on Twitter, Ash Hennessy, and then our coalition's group website is climatehealthnow.org. So yeah, thank you.
This is great, Ashley. Thank you for your enthusiasm and passion for this. I also think that your favorite slide was my favorite slide. It's really great speaking out in this realm as a climate and health advocate is that there's so much support. And so, you know, you mentioned a couple of them, AMSA, Healthcare Without Harm, Medical Students for Sustainable Future, Alliance of Nurses for Healthy Environment, Climate Health Now, all of these organizations, there's just so much support in anything that we do. And I really think the more we band together, obviously, the more impact that we can make. I don't know if anyone missed what was some of the things that were being said in the chat, but Dr. Amy Collins, who's great, had a little shout out for Healthcare Without Harm, which is an organization that supports hospitals and health systems in building resilient healthcare and creating climate smart healthcare. And they have a report on the Safe Haven in the Storm, which analyzes the losses and resilience related savings to demonstrate how preparing for extreme weather can make or break a healthcare system. So from there, if anyone has any more questions, please feel free to put them in the chat. But I just want to start off with sort of a personal kind of question, just because there was a really interesting article that came out in the Atlantic 4 days ago that some of you might have read about performative environmentalism. I am of the opinion that if we mandate people, lawmakers, to have climate smart solutions and to really be effective climate advocates, we have somewhat of a moral obligation to mandate ourselves to lead somewhat of a climate friendly or sustainable lifestyle. And I don't really see it necessarily as performative, but I was just gonna reach out to both Dr. Mcclure and Dr. Rublee to see what in your own lives have you found to be small effective steps that you've taken to create a more sustainable lifestyle.
Do you want to go first, Caitlin?
Sure, absolutely. So that's an excellent question. And I think it comes down to individual versus systemic change. And certainly we can focus on our individual actions even as employees, as part of large health systems. And that matters. But at the end of the day, we know, divestment from fossil fuels, we know these large systemic changes are needed in order to improve the trajectory that we're currently at and the human influences to climate change. And so I think, talking about at an individual level is important, but doing so with a lens on much broader issues so that we're able to engage our community, engage our health systems, and engage all the different organizations and viewpoints necessary in order to successfully create some of these changes in behavior. It's kind of like reading a nutrition label, right? So nutrition labels are readily available and still obesity is not cured, right? So how in the same way do we implement toolkits and guidance documents and all of these excellent examples that we already know into healthcare systems and communities in order to create real change?
Yeah, I would say I have heard that a large fossil fuel company, or perhaps a coalition of them, promoted the personal carbon footprint notion. And I think it's a good distractor because we know that our individual, I think in terms of individual efforts to really contribute to the larger goal of stabilizing the climate for our kids, is the individual thing is linking arms with people like you. And it's about activism. To me, that's the individual effort. It's not, be plant-based, ride your bike, but especially because we're physicians and nurses, and we have this incredible, like I said, climate superpower, which is our voice. There's a reason there's like a T-shirt that says, "Trust me, I'm a doctor." And I think what our greatest contribution is not what we as physicians are eating, it's what we are saying in like the social narrative that we need to me, that's the individual like the highest leverage individual effort is using our voice to connect it to things that people understand as personal and about their own health and their kids' safety, much more so than what we're doing individually. There's a great Doctors for, or it's an Extinction Rebellion video, and they say, you know, if we all do a little bit, it adds up to a little bit, you know, and it's policy, it's collective action. Of course, everybody knows that, but I just think, you know, it's really important to just keep using our tools to the top of our license, right? Which is using our voice for policy.
Definitely. Thank you for that from both of you. Dr. Rublee, this is a question I think geared a little bit more towards you. And the question is, what's being done to educate hospital administrators regarding both simple and more extensive ways for conservation efforts and sustainability?
Yeah, thank you for that question, Michael. It's excellent. So there's several different ways. Number one, there are state chapters for the consortium, and many of them are actively reaching out to healthcare systems within their own state to work on low carbon emissions from their healthcare facilities. There are also green teams at different facilities, and as part of those green teams, one of their roles is to directly educate members of their healthcare system, and that includes from the business side. And then thirdly, Healthcare Without Harm and Practice Green Health have different memberships which are available, and they can help guide these interventions and find, again, kind of low-hanging fruit in addition to larger initiatives that can really transform healthcare systems. I would say too, coming from an academic facility, students are really driving many of these initiatives. So quality improvement projects are mandatory parts of residency education. And so simple things like assessing waste, for example, in the emergency department is being done across systems.
That's great. Great response. Thanks, Dr. Rublee. And then Dr. McClure, there's a question about, has the AAP committed to divesting? And the bigger question might be, how can we find out what health organizations have committed versus not committed?
Yeah, it's a really sad small percentage. The website I use, so AAP, I don't know. I don't think so. But I am not a pediatrician, so I'm not actually sure. I know AMA has, but I'm not aware of AAP. But the tool that I go to is, if you Google Divest Invest, then they have a spreadsheet of kind of a compilation of all the divestment pledges. There may be others, but that's the one that I use. And I can say the last time I looked, they break down kind of all the sectors that have pledged divestment to total that $14 trillion, and 1% is in the healthcare industry. And most of those are abroad. You know, they're not, I think the only one, and Amy could maybe add to this, in the US, it's Dignity Healthcare. And then there's one in like the Midwest whose name is escaping me right now, but it's like just this minority, and it, with our mission, you would think we would be leading, but we're not. So yeah, Divest Invest is the website that I go to see the pledges.
That's great. I don't see any more specific questions. Thank you, Megan Whitman, for sending out that Atlantic article. It's a great read if anyone hasn't seen it. And thank you everyone else for all the information that you put in the chat. Is there anything else that either of you would like to say before we conclude?
It looks, Nila, it looks like one more just came through in the chat, in the Q&A.
Oh, great. So it sounds like, I think this is for Dr. McClure. The question relates to the first goal, when it is stated that action should be taken when the system's policies are not in line with the goal of no more than a 1.5 degrees Celsius rise in temperature. What would be specifics of not being in compliance, and could a health system somehow feel they are in line with this goal and use this to avoid divesting?
I'm sure they can rework it to avoid. But you know, with the carbon bubble that exists, and the amount of kind of fossil fuel reserves that are held by so many private companies, the answer to in line with the 1.5 degree pathway is like to stop burning fossil fuels tomorrow. So it's basically an immediate or transition that's required. There's no more. If this was 1990, yeah, it would be like kind of phased in. But the answer is it's stop burning fossil fuels, leave it in the ground now. Yeah. Does that answer the question? Yeah. And then I did want to say one other thing though. So we have 60 days, I think, till the election. And I did want to share, there's this super cool toolkit I just learned about that's focused on, it's built for health professionals, doctors and nurses. And it's about kind of turning out 100% of the healthcare sector to vote and also to help register our patients to vote. As an empowering thing. It's very nonpartisan. It's just about like civic engagement, which is totally in line with 501c3 limitations, is just voter registration. So I just put it in the chat, but it's a really, really cool toolkit to help get your colleagues registered to vote, because right now doctors vote less than the average public. So we got to fix that. And it has like a QR code that I've been showing my patients during video visits to help them register. So a really cool way to empower patients to feel like their voice matters. So.
And I joined the Voter, like the VOTER, which is also, and they'll basically, if you go to their website, they will mail you something that you can wear around your neck that also has a way for people in the clinic to find out if they're registered to vote and to register.
Exactly, really similar. But that one has sort of a delay. This other one is like right now. So they're very same spirit, but if you don't want to wait, then maybe the Vote Health 2020.
That's very true. Yeah, I had to wait a few weeks for mine to come. Kelly DeMarco, we will have access to the slides. Colin will be sending those out. And, I think you bring up a good point about therapists. So I actually recently wrote a piece in Scientific American where I talk about some of the health effects of climate change, but I also have been so impressed with how many different healthcare professionals, medical students, physicians, nurses, pharmacists, and therapists who have expressed so much interest in this. And one of the things is that when I wrote it, I was able to reference like a nurses organization and medical students and physicians, but I actually did not find one for therapists per se. So I don't know if anyone else has run across an organization specific for therapists, or if you could start one yourself, which would be amazing. But I agree. I do think there's a lot of therapists, whether you're PT, OT, speech therapy, who are very interested in this. But I have not yet come across an organization myself that is specifically only includes therapists as climate advocates. And again, I'm sorry for not having the CME webinar links, but those will be sent in your email. Don't worry, you will be able to get the credit for it. And we're really excited that everyone was here and joined us. And thank you so much to Dr. Mcclure and Dr. Rublee for being here today and chatting with us. And thank you to Colin and Wendy for all of your help and support.
Yeah, our pleasure. Thank you. Bye, everybody. Have a good weekend.